Morning, all. Topic of my discussion today is interrupted aortic arch. So, first, coming to the introduction, interrupted aortic arch is a rare cardiovascular disorder where there is a lack of continuity between the endolumen of the ascending aorta and the descending aorta. It is present in approximately 2 cases per 1 lakh live births and comprises 1.5% of all cases of congenital heart disease. The natural history of interrupted aortic arch has a mortality close to 75% in the first month and 90% by first year. Despite the remarkable progress in the management of complex congenital heart malformations, the mortality and morbidity associated with surgical treatment of interrupted aortic arch and the spectrum of its concomitant anomalies remains substantial. The few areas of controversy include not only the choice of procedure but also the timing and staging of the repair, assessment and approach of associated obstruction or hypoplasia of the left ventricular outflow tract, and the intraoperative strategy for cardiopulmonary bypass. Additionally, important late phase events after repair susceptible to discussion are related to the potential for development or recurrence of systemic venous outflow tract obstruction, aortic arch obstruction, or both. History. The first description of an interrupted aortic arch is attributed to Stadel in 1778, which involved the absence of the aortic isthmus. In 1955, Sampson and his colleagues performed the first successful staged repair of interrupted aortic arch in a 3-year-old child. In the initial operation, the patent ductus arteriosus (PDA) was divided and the descending aorta joined to the underside of the proximal left subclavian artery. The ventriculoseptal defect was closed 4 years later. The first use of turned-down aortic arch branches, left subclavian or left common carotid, to achieve end-to-end anastomosis to the descending the thoracic aorta was described by Sirac and colleagues in 1968. In 1970, Litwin and associates palliated a neonate with arch interruption and VSD by interposition of a prosthetic tubular graft between the proximal male pulmonary artery and the descending thoracic aorta with banding of the distal main pulmonary artery. In 1975, Trussler and Izukawa were the first to accomplish direct anastomosis of the descending aorta to the ascending aorta and arch and transverse arch together with VSD closure via median sternotomy during deep hypothermic circulatory arrest. Primary repair without a period of circulatory arrest was first reported by Asso et al. In 1996. Digeot syndrome and its closely related velocardiofacial syndrome were subsequently found to be due to chromosomal deletion in the region of 22q11.2. This deletion is frequently seen in conotruncal defects, being present in 48% of those with interrupted aortic arch. Embryology and anatomy. The development of the aorta starts during the 3rd week of gestation following a very complex ontogenetic process known as vasculogenesis. Most aortic arch anomalies can be explained as disruptions of the aortic arch formation with the persistence of areas that should have adequately degenerated or have degenerated at abnormal points. The most widely accepted classification of interrupted aortic arch was originally described by Abbott in 1927 and completed by Celoria and Patton in 1959. They divided interrupted arch variants into A, B, or C based on the site of the aortic arch disruption. Coming to the classification, this is the type A. So as we can see in the right side of the image, the type A refers to the interruption at the level of the isthmus distally to the left subclavian artery and represents up to 30% of all interrupted aortic arches. Embryologically, this is because of the lack of connection between the left fourth arch and the left dorsal aorta, which in turn displaces the origin of the subclavian artery to the left third aortic arch. Coming to type B. In type B, the interruption occurs between the left common carotid and left subclavian artery and results from an abnormal degeneration of the proximal portion of the left fourth arch, leaving a gap between these two vessels. It is by far the most common of all interrupted aortic arches, being found in up to 70% of cases. Type C. Finally, in interrupted aortic arch type C, the interruption is proximal to the left common carotid artery. In this circumstance, the left horn of the aortic sac regresses, producing a complete disconnection between the left common carotid artery and the innominate artery. It is the most infrequent type of interrupted aortic arch seen in only 1% of cases. Herein, abnormal right subclavian artery is noted in about 50% of patients with type B interrupted aortic arch. It is associated with hypoplasia or obstruction of the LVOT as there is less antegrade flow from the left ventricle. Rarely, the site of origin of the right subclavian artery is a persistent right-sided ductus. The few associated cardiac lesions and variations. Nearly all have large VSD with malaligned conal septum, comprising almost 73%. Common lesions, truncus arteriosus of about 10%, aortopulmonary window 4%, TGA with VSD 3%, univentricular AV connection 4%, double outlet right ventricle 2%, complete AV canal defect 4%, and congenital corrected TGA 0.4%. LVOT obstruction is common. It may be of two types, fibromuscular or valvular stenosis. Pathophysiology. Ductal dependent lesion. Blood flows through PDA due to interrupted arch. Pulmonary vascular resistance versus systemic vascular resistance, which influences the shunting. Complex left to right shunt via VSD impacted by LVOT obstruction and arch interruption. Clinical features. Early neonatal period may have subtle signs, CHF signs once PVR drops with ductal patency. Ductal closure leads to shock differential cyanosis variable due to anatomy. PP differences not always reliable with apparent right subclavian artery. Prenatal diagnosis. 2D echocardiography is sensitive from the first trimester. 3D fetal echocardiography with spatiotemporal correlation enhances accuracy. Fetal cardiac MRI, motion corrected cardiac MRI valuable unaffected by fetal position, and it is effective in diagnosis both type A and type B. Postnatal imaging, detailed 2D or 3D echocardiography for arch, VSD, LVOT obstruction, CT and MRI, 3D reconstructions for extracardiac vascular anatomy. Cardiac catheterization, indicated for pulmonary artery anatomy verification and ductal patency maintenance. Preoperative consideration. Interrupted aortic arch is incompatible with life without an open ductus arteriosus or an alternative pathway for perfusion of the lower body. Therefore, preservation of ductal patency with an infusion of prostaglandin E1, PGE1 is a must. This allows for recovery of renal and hepatic function, aiding in the correction of acidosis and optimization of respiratory parameters, fluid and metabolic status, as well as correction of coagulation disorders. Once this patient is stabilized, it is pertinent to assess the neurological status. Genetic evaluation can be initiated to provide a more accurate family education and counseling before the proposed treatment is undertaken. An operation is usually indicated as soon as these preliminary objectives have been achieved, since there is no definitive medical therapy for interrupted aortic arch. Medical management. Maintenance of ductal patency with PGE1 infusion, metabolic and respiratory optimization, neurologic assessment prior to surgery, genetic screening, 22q11 deletion is common, impacts perioperative care. Surgical decision algorithm. Primary repair if aortic annulus diameter is more than weight in kg plus 1.5 mm. That is, if aortic annulus diameter is 3.5 to 5 mm, then primary repair is indicated. Higher LVOT risk, higher LVOT obstruction risk if diameter is between weight plus 1 and 1 is weight plus 1 and plus 1.5 mm. That is, if weight is between 3.5 to 4 mm, then there are higher risks of LVOT obstruction. Yasui or Roscono, the procedure is preferred if diameter of aortic annulus in mm is less than weight in kg. Now, in these cases, consider staged or hybrid if contraindications to CPB. Operative management. Monitoring and anesthesia protocols. Right radial and femoral or umbilical artery lines to monitor blood pressure and cerebral and somatic oxygen saturation using NIRS. Cardiopulmonary bypass strategy. Antegrade cerebral perfusion, moderate hypothermia, target NIRS score of more than 75%, right radial pressure of 30 to 35, 30 to 50 millimeters of mercury. Cannulation. The innominate artery is cannulated either directly or most commonly via a 3.5 mm Gore-Tex graft. Subsequently, both vena cava are cannulated to facilitate intracardiac repair. A left atrial vent is placed and an additional cannula may be optionally inserted into the PDA for more effective perfusion of the lower body. After starting CPB, the pulmonary arteries are snared and the patient is cooled down to the desired temperature. High flow full body perfusion strategy with mild hypothermia with balanced cerebral or somatic perfusion. Herein, after the standard cannulation technique for ACP antegrade cerebral perfusion, lower body perfusion is provided by direct cannulation of the thoracic aorta with an 8 French arterial cannula. To achieve this, the thoracic aorta is partially dissected and cannulated after lifting the apex of the heart and opening the posterior pericardium transversally while in CPB support. Or alternatively, distal perfusion can be provided via percutaneous cannulation of the femoral artery before surgery with a 4 French sheath. Deep hypothermic circulatory arrest DHCA. For complex cases, intermittent DHCA with NIRS guidance. Arterial cannulation may be done directly into the ascending aorta and somewhat laterally placed. The remaining steps may be the same as described in antegrade cerebral perfusion. Myocardial protection. The entire repair is performed while the aorta is cross-clamped with repeated deliveries of cardioplegia solution according to the surgeon's preference. Primary cardiac repair preferred significant sequence of surgical steps consists of patch closure of the VSD during cooling, followed by arch reconstruction. VSD closure, transatrial or transpulmonary approach depending on conal septum. Wedge resection of posterior conal septum if moderate LVOT obstruction is present can be done via tricuspid valve. Aortic arch reconstruction, PDA transection and mobilization of the descending aorta, end-to-end anastomosis to ascending aorta or proximal arch, patch augmentation for tension relief and hypoplastic segments, pulmonary artery homograft is preferred. Herein is an image wherein the aortic arch reconstruction is done by aortic end-to-end anastomosis and patch augmentation. So we can see in figure A, the SVC is cannulated, and apart from that, the ascending aorta and the descending aorta is cannulated, and there is looping of the patent ductus arteriosus, which then is anastomosed by end-to-end, which then is anastomosed with end-to-end with patch augmentation. Reverse subclavian flap technique, ligation and flap creation from left subclavian artery to enlarge the arch. Alternative and staged procedures. Yasui operation, combined norwood arch reconstruction and rastelli repair, intraventricular tunnel and damascule stancil anastomosis. Roscono operation, used when aortic annulus or root may be too small for primary repair, combines with aortic arch reconstruction with pulmonary autograft placement. Staged repair strategy, off-pump neonatal arch repair with PA bunding, VSD closure delayed to 2 to 3 months of age, suitable mainly for type A interrupted aortic arch. Hybrid palliation, bilateral pulmonary artery bands and ductal stent reserved for high-risk neonates or unstable patients. Postoperative considerations, early post-op monitoring with TEE, pressure gradients, calcium monitoring for 22q11 deletion syndrome, early post-op complications, chylothorax, nerve palsy, left bronchial compression, residual or recurrent LVOT obstruction, VSD, tricuspid regurgitation. Outcomes and long-term prognosis. Early mortality and survival: 12% early mortality overall, 3.2% in isolated interrupted aortic arch. Risk factors may be aberrant arteries, prematurity, low weight, delayed sternal closure. Late survival and quality of life: more than 90% survival at 10 years in simple lesions, 60 to 80% survival at 5 years with complex lesions. Neurodevelopment and functional delays common in 22q11 deletion. Reoperations: freedom from reintervention, 78 to 82% and 15 years. Common reinterventions: LVOT obstruction, arch obstruction, bronchial compression. LVOT management. LVOT obstruction management: 20 to 40% incidence in post-op complications. Reoperation influenced by smaller initial LVOT dimensions. Surgical interventions can be myomectomy, valvuloplasty, extended ventricular septoplasty, or Roscono procedure. Aortic artery interventions: factors for recurrence, aberrant arteries, complex anatomy. Increasing role of stenting in selected cases. Left bronchial compression caused by displaced descending aorta. Diagnosis is by or dynamic CT or MRI. Management: aortopexy, aortic elongation, pulmonary artery repositioning. Thank you, sir.
Thank you. Separately good presentation. It's a rare condition, you said 1.5%, but usually the literature sometimes says about zero point 0.7 to 1% of the congenital cardiac anomalies. And you mentioned the accepted classification, the Celoria pattern classification ABC, uh, described in 1959. The A is beyond the left subclavian, B is between left subclavian and left common carotid, and C is between the after the innominate between the left common carotid, and that's a rarest is at 1%. The most common is type B. Uh, Very often it's associated with other conditions. One of the usual associations is the abnormality of the subclavian. In that, number one is a normal subclavian. That means at the last branch of the aortic arch. Number two is an aberrant subclavian. Aberrant subclavian is one which arises from the descending thoracic aorta, crosses to the left side between the trachea and the esophagus, causing compression to the esophagus, what we used to call lusoria, dysphagia lusoria. And the third is subclavian anomaly, where the subclavian arises from the ductus arteriosus. And you said this is common. About 15% of the patients with DiGeorge syndrome.
Yes,
You
sir.
know what is DiGeorge syndrome? What other names that's actually? It's also known as velocardiofacial syndrome. Why they call velocardiofacial syndrome? And what are the components of a DiGeorge syndrome? And finally,
The ventricular septal defect is there, sir. Conotruncal abnormalities.
uh, you know the mnemonic to remember that?
Sir, catch 22.
Yeah, good. What's catch 22?
Sir, see this cardiac defects
Very
and
good. Very often, conotruncal, VSD, truncus, okay. Interrupted aortic, very good.
Sir,
A,
A stands for some abnormal facies.
very good. Yeah.
The T is thymic hypoplasia.
Thymic hypoplasia or aplasia. Okay, very good.
Sir, the next C stands for cleft palate.
Very good. That's a below. In Latin, below means the palate, below cardiophagia. Yeah, good.
And sir, this hypocalcemia is also associated, sir.
Very good. And 22 is the micro deletion of the 22q11.2. Yeah, that's
Yes.
why it's a cat 22. Then. Sometimes these patients, we do a fish test. Why do you do a fish test? What's its importance in surgery?
Uh, I'm not sure, sir.
That's a way to identify the genetic abnormality. Fish is A for fluorescence in situ hybridization. The probe which easily you can find out whether there's a genetic abnormality or not actually. If the fish test is positive, what precautions do you take during surgery? I'm sure you do routinely in this hospital. Some, they say you give irradiated blood. Why you give irradiated blood?
Sir, because in blood oxalate is present, so it may react with the like the
Yeah,
blood components.
not exactly. These patients with thymic aplasia, the if you don't give irradiated blood, the donor T cells, you know,
Yes, sir.
react with a GVH, a graft versus host, because the uh, recipient doesn't have that T cell. When the T cell from the donor acts as a graft, and it reacts with the recipient. That is the graft versus host reaction. And postoperatively, a GVH is almost 100% fatal. So that's why generally in such cases, we give irradiated blood. That's a must. That's what we do in NS.
Yes, sir.
Yeah. Then in these cases, something, if the George syndrome is there, you don't very often give what the usual anticoagulant used in blood transfusion?
Sir, calcium oxalate is present. Then
Yes, Mr. It used to be in old time ACDs. Acid citrate dextrose used to
yes,
be
sir.
there.
Yes, sir.
Now citrate phosphate dextrose is given. How does it act as an anticoagulant?
So it will chelate with calcium and stop the coagulate.
Very
This
good, very good. Chelation and the calcium give- is completely taken up, and so the clotting factor is removed. So in a patient with DJOS syndrome, there's already hypoglycemia, hypocalcemia. So if you add this also, the patient very often goes into extreme hypocalcemia and even tetany. So usually don't give them ACD or citrate phosphate dextrose anticoagulated blood, but you give them heparinized blood actually. That's what is okay.
okay, sir.
This is the uh, general about these patients. And then about the previously palliative operation, the previously there used to be a stage procedure, And one of the first you said subclavian turned down, and that is insufficient to give blood supply to whole of the lower part of the body. That's given up, you know. Then there's to be another palliation where left thoracotomy, uh, the ascending aorta, partial clamp, anastomosis to the main pulmonary artery. It's a very complicated procedure done from the left thoracotomy without cardiopulmonary bypass. Anastomosis the ascending aorta with a partial clamp on the pulmonary artery, make an anastomosis, and then do bilateral pulmonary artery banding. And as a second stage, go and repair because 90% of these uh, patients, as you said, have got a ventricular septal defect.
Yes, sir.
And because of the ventricular, why these patients don't have differential cyanosis? If a patient has got a pulmonary artery, a ductus continuation, has a descending thoracic aorta, they all should have differential cyanosis because the pulmonary artery blood, which is less saturated, is coming to the leg. But in interrupted aortic arch, you don't get a differential cyanosis. Why is that?
Because ventricular septal defect is present, sir.
Very good. 90% I got ventricular septal defect and the pulmonary artery saturation is very high. So the lower limb saturation never goes below 85%. Okay, good. And the presentation is exactly like a pre-ductal coarctation. That means when the ductus closes in a pre-duct, actually interrupted aortic is a some sort of a complete coarctation, but only at a proximal level, at the arch level.
Yes, sir.
And in a pre-ductal coarctation, the classical presentation, how do they classically present? After birth, how do they present when the ductus closes? But usually the physiological closure occurs really in the anatomic closure. So within 12 to 14 hours, it starts closing. By 1 or 2 years, they, they present with severe no blood supply to the lower part of the body, severe ischemia to the lower part of the body. Uh, Kidney is affected because urinary output comes down, and severe lactic acidosis, and they present with a severe shock-like syndrome because of that. That's a classical presentation of a pre-ductal coarctation, and that's a type of presentation in these also. So that's why these patients, within 4 days, you have to start them on PGE1 for keeping the patency of the ductus arteriosus. That's why these days, by fetal echocardiography, these abnormalities are diagnosed and then they transferred to a tertiary cardiac center so that immediately you can start them on PGE1 and then do surgery as required, you know. Then nowadays, most people do uh, complete correction, one stage repair.
Yes, sir.
That you said, in that the cannulation is most important. In the innominate artery or the ascending aorta is cannulated. Very often, the type C interruption, only the innominate is arising from the aorta, so the aorta is very small. So that's why you said sometimes the innominate is convoluted with a graft, you know. Okay. Then very often you cannulate the pulmonary artery near the ductus because it's very difficult to go up to the ductus and cannulate, you know. So pulmonary artery is cannulated. Before the pulmonary artery cannulation came, they tried to cannulate the femoral artery. That means For the inflow from the pump, one goes to the innominate artery or the ascending aorta, and side branch goes into the femoral artery. But the problem is in a neonate or two or three, if you cannulate the femoral artery very often, you destroy the whole femoral artery and they get problems, you know. So that's why it's better to cannulate the pulmonary artery. In which other condition you cannulate the pulmonary artery? For events, sometimes you do it for coronary artery bypass and other things. I don't know whether we used to do it long time ago. Instead of a right superior pulmonary vein to decompress the heart, pulmonary artery vent used to be put. But for arterial inflow, it is be cannulated for a hypoplastic left heart syndrome, stage 1, Norwood 1 procedure. It's cannulated and then cooled to deep hypothermia and circulatory arrest, you know. And then you dissect out the cerebral branches and you clamp them. And then you do procedure. And you showed the procedure. There are two types of procedures done. One, originally not done nowadays, is under deep hypothermia circulatory arrest. You anastomose the ascending aorta to the pulmonary arteries. Of course, then you open the main pulmonary artery and put a patch in such a way the aorta and the pulmonary artery is separated. But that also I don't think is done very much now. What you showed in the diagram is actually mobilizing the descending aorta and then anastomose it and to the side of the ascending aorta. And sometimes, you know, the length is not enough and there may be tension on the anastomosis, though you can use a homograft for it, or sometimes full homograft or homograft patch is used anteriorly, you know. So the idea is to uh, move the mobilize the whole descending thoracic aorta and anastomosis. That is it, depending on the type of interruption. And the VSD is close transatrially, and all intracardiac procedure is done in one stage. And that procedure used to have a very high mortality, but now everything is very sophisticated. And some single centers say even 0% mortality. But usually it's about 10 to 20%, you know. And you also said the natural history of this is about 90% of them don't survive 1 year. They all die in the first year of life. Uh, and also, even though nowadays the uh, surgical mortality has come down, there is about 20 to 30% of reintervention rate in most of the cases. Either because the aortic valve may be very narrow, because the main output is into the pulmonary artery. The aortic output is only in the type 3 to the innominate artery. So the dimension of a vessel depends on the amount of flow come through that, you know. So it's a very small. And that's why many of them, 60%, have got a bicuspid aortic valve and very narrow aortic root, as you said. Some of them may later on repair a corner repair in such cases, you know. So that is one. Subaortic stenosis may be there. Then some of them have got truncus arteriosus. Some of them have got a transverse to the great artery. So it's a complex situation, and the mortality depends on how complex is the congenital anomaly in such cases, you know. And reintervention, either surgical, nowadays many reinterventions are based on catheter, also can be done. And the other thing, you didn't mention anything about the as I always say, the experience in Narayana Hridaya area, because you never see many cases. Have you any idea, or have you talked to anybody about our experience of intermittent aortic arch, of the type we see, and what the repair we do?
No, sir. I could not get their input, sir.
Okay. Next time, at least you find out, what is the
Yes, sir.
statistics, our statistics in such cases. I'm sure we often don't do any palliative procedure. We usually do uh, complete repair in one stage, because the combined morbidity and mortality of a first stage repair followed by a second phase complete repair is much more. So very often it's easier to do a one stage repair in such cases. So just find out uh, from your seniors and also and you can get statistics from Narayana Vidyalaya. How often you see that, and which is the most common type? Usually type B. You said 70%, I said about 50%. Anyway, it's the most common type of anomaly, very often associated with anomaly of the subclavian artery, and very rarely a right-sided descending thoracic aorta. That means after the arch, the descending aorta comes on to the right chest, instead of proceeding through the left chest. That's one anomaly. So just find out what is our statistics, because that's one you have to know any oral examination in your exam. Okay.
Sure, sir.
None of you have seen a interrupted aortic arch correction? Nobody has seen it. Have you seen? Huh? It's breaking. Yeah.
Sir, does this patient tolerate deep hypothermic circulatory arrest, sir? Like so young?
Actually, deep hypothermic circulatory is for smaller babies. They tolerate very well, actually. In fact, such a very small patient, deep circulatory deep hypothermia circulatory arrest, very often don't need. It's very difficult to create antegrade cerebral protection. So you do operation fast in about 30 minutes or 35 minutes. So deep hypothermia circulatory arrest is a standard procedure for very small babies. That's how started originally the uh, deep hypothermia circulatory arrest was started originally. You know that. The Because extended cardiopulmonary bypass is very lethal in small babies. That's why originally if you read your old books of Kirkland, it's a originally Japanese technique. I don't know whether you know the history of deep hypothermia circulatory arrest. Initially, all the small babies, they are ventilated, chest is open. Before chest is open, uh, surface hypothermia, ice packs all around in a pot full of blood, I know, cold fluid and ice packs. The patient is allowed to have a uh, surface hypothermia. That's originally the hypothermia technique developed. And then when the temperatures come down to about 28, 29, because if you go beyond that surface hypothermia, the heart fibrillates at that temperature. So take them out of this bath and the ice packs are removed and you open the chest and then uh, cannulate and cool another 5 minutes or 10 minutes, rapid cooling. The whole idea was because to reduce the cardiopulmonary bypass time. So the original Japanese technique was the surface hypothermia followed by a on-pump hypothermia to get to a temperature of 18 to 20. At that stage, stop the pump, do the surgery, and then rewarming is done on pump. So the actual bypass time is about 5 to 10 minutes before circulatory arrest, about 30-35 minutes after the cardiopulmonary bypass. On cardiopulmonary bypass, after the main surgery is completed, that used to be the Japanese technique. That's what uh, Barrett boys popularized in the Western literature because the Japanese literature could not be read by the most. So that's how the original technique of surface hypothermia and followed by a pump hypothermia and circulatory arrest came for neonates. So it's a very safe procedure. Now nobody does surface hypothermia. They do only on pump cooling and on pump rewarming and go to temperature 18 to 20 and stop circulation. Take the venous cannula and do the surgery now. So it's very safe. Even neonates, it's the safest procedure. Rather than prolonging the cardiopulmonary bypass time in neonates. I'm sure you must have seen neonatal coarctation for pre-ductal. I'm sure that's commonly done in our hospital, no? When the neonatal coarctation, the pre-ductal, when the ductus closes, the circulation to the lower part of the body almost comes to nil, and these patients with severe lactic acidosis, shock-like syndrome, operated as emergency. That's neonatal coarctation. Same thing happens in interrupted aortic arch also. When the lower part of the body, the circulation depends on the patency of the ductus arteriosus. That's why medically you do it by PGE1, and as soon as the patient is fit, do the surgery. Any other question? Anyway, you find out our statistics. That's important. Okay.
Yes, sir.
Anybody else? Any? Can't hear.
Sir, while operating,
Yeah.
how is about the left main bronchus dealing with this in while repairing? It will come in between, no, sir. So how to?
No, it doesn't come. It's all in front. That doesn't come in the way at all.
Okay.
It's a posterior structure. So you're approaching with the median sternotomy. That's all. The arch and the most of it nowadays, a combined VSD is coarctation. In our time, the classical teaching was if the coarctation is very severe and VSD is very small, do the coarctation repair first from the left thoracotomy, do the coarctation repair, and then leave the VSD open for uh, automatic closure or closure later on by surgery. If those days, if the VSD is moderate size and the coarctation is significant, the classical teaching was do the coarctation from the left side and do pulmonary artery banding, and later on, as a second stage, do the VSD. Nowadays, if the coarctation is significant, VSD is large, most of the pediatric cardiac surgeons do it as a one stage. From median sternotomy, do the coarctation and the VSD both in a single sitting. That's what is done nowadays. So that's very often. Sometimes they ask you in exam, what happened? What's your procedure of action when there's a combined coarctation with a large VSD? So in our hospital, it is done usually at a single stage per median sternotomy. That's what's done. But if the VSD is very small, the usual answer is do the coarctation first and wait till watch and observe the VSD for a long time. If the VSD is moderate, some people used to say do banding, but nowadays banding is not preferred because the complications of banding and the correct amount of the constriction achieved by banding is variable. And very often they outgrow that. So banding is not generally preferred in our hospital. Okay. All right. Okay, then we'll stop. Sujit, are you there?
Yes, sir.
Okay. All right. Thank you very much. Thanks.
Thank you so much, sir.
Thank you.